All right. Hi, guys. So, last session. Hopefully, it's nice and solidifies every last thing you need to know before your exam. So, today we're going to be talking about fibrinolysis in general. And towards the end, we're going to talk about DIC versus primary fibrinolysis. A lot of the times, it's like using the lab values to figure out which one's happening. Then, we're going to go into what I call the heme farm. The heme farm is a bunch of different stuff. Oh, I don't know what this is. Okay, cool. Um, all right. The heme farm is like what I call heme farm. So it's like anticoagulants, antiplatelet drugs, thrombolytics. We're going to talk about another drug called deferoxamine and then NSAIDs. NSAIDs, I do not go into the level of detail that you need to know NSAIDs for, you know, life, and especially not for boards. They want you to know NSAIDs pretty in depth on boards. So that's why I say please review again in like cardiorenal pulm. That's like actually where you're supposed to do NSAIDs, technically supposed to. But for this, at least, we're going to talk about NSAIDs very briefly and then talk about its role on prostaglandin. So it's kind of relevant a little bit with the heme pathway. And then don't forget that desmopressin. So we did talk about desmopressin a little bit in the primary hemostasis lecture. Desmopressin is an ADH analog, so you're going to cover it in detail in the renal block. But just remember, I just wanted to remind you guys, because it's not technically a heme drug or an oncology drug, a chemotherapeutic. But remember that desmopressin increases VWF for some reason, von Willebrand factor. So it's actually a viable treatment for von Willebrand disease and even hemophilia A, again, depending on how bad your hemophilia A is. Because you can remember factor 8 and von Willebrand factor kind of go together. So if you have a massive decrease in hemophilia A, you can technically have a massive decrease in von Willebrand factor. So you can give desmopressin for either one. But I just wanted to put that out there to remind you that that is a thing. So first we're going to go into fibrinolysis. So the first thing we're going to talk about is fibrinogen. So don't forget the names of these things. So fibrinogen, another name for it is factor 1 in the coagulation cascade. So please remember that. But this is a clotting factor, right? So it's going to get consumed. It's a zymogen, right? So it's going to get consumed to get converted to activated factor 1, right? During clotting. So this is what it looks like. It's this really long strand. It's made in the liver, just like most of the clotting factors. Not all of them. Remember, some of them are made in endothelial cells. Remember that chart. So this one's made in the liver. And during coagulation, it is converted to fibrin. And thrombin is what converts it to fibrin. And then it's just, I wanted to put the reference range here, but as a reminder, use whatever reference range they give you. On STEP, COMLEX, your PBL exams, use whatever they give you. But in general, it's important to kind of just have an idea of the reference range, because remember, this is going to get converted, so it's going to get depleted. If clotting is active and we're running through the coagulation cascade, we're going to have decreases in the factors, because that's a zymogen pathway. It's the same with the complement cascade. Okay, so like let's say we have like 100 milligrams per deciliter of fibrinogen in a practice question, and then you're like, wow, that's pretty low. That just tells me that fibrinogen is getting converted to fibrin, to activated factor 1. All right, so clotting is taking place. So if we zoom in on our fibrinogen, our factor 1, what does it look like? So it has these D subunits on the ends, so that would be like here and here, and then it has an E subunit in the middle, and then the E subunit has alpha and beta chains connected to it, so that's what's here. And this is soluble, so it's soluble, it's just because it has these chains on it. Well, it's soluble for other reasons, but it's soluble. This is soluble fibrinogen. And again, when you're making a clot, we don't want it to solubilize super quick, like super easily. So the goal is to make an insoluble fibrin clot. That's the whole goal of the clotting cascade. So what happens? Fibrinogen, factor 1, gets converted to fibrin, factor 1, activated factor 1. And thrombin does this. So thrombin, I should have had factor 2A, because technically prothrombin is factor 2, but thrombin is factor 2A. And what thrombin is doing is it's removing these alpha and beta chains. And this gives you a true fibrin monomer. So that's the only difference between fibrinogen and a fibrin monomer, is the removal of these alpha and beta chains. So we still have our D subunit, our E subunit, and then our D on the other side. It's still soluble. then a lot of these monomers kind of congeal, they come together. And a lot of the times it's from these hydrophobic interactions. I believe it's hydrogen bonding. And it's a very weak, so it's a bunch of hydrogen bonding, which again is not very strong. It's not strong bonding. It's a strong hydrophobic interaction, but overall it's not a very strong connection. And that's what gives you what's called a fibrin gel. So this is a gel. It's still soluble. But what you can see is kind of like these monomers are lining up. They're coming together. They're interacting with their hydrogen, and they're forming hydrogen bonds to kind of like hold near each other, and that's what gives it this gel-like appearance. But it's again not super stable. It's still soluble. And then from here, this is where factor 13A becomes really important. So factor 13A, this is fibrin stabilizing factor. It does exactly what it says. It's going to stabilize this fibrin gel. And what it's doing is it's going to add these cross-links. And these cross-links are covalent bonds. So factor 13A is able to add these covalent bonds, and where it adds them is to the D subunits that are right next to each other. So what we have here are dimers of these D subunits. Hopefully you can see where I'm going with this, but this is kind of like, once you have these cross-linked D subunits, we know that factor 13A was activated. We know that we have a true cross-linked fibrin clot because now it's insoluble. Cool. So we have our clot. How do we break our clot down? Like, how do we break our clot down? So what's going to activate fibrinolysis? And again, it's like we don't want clots all the time. We need clots for certain amounts of time, and then we need to break them down because we don't want to be hypercoagulable, right? That's not good. That's like a pathology state. So one of the best ways that the body activates fibrinolysis is just endogenously releasing TPA. TPA stands for tissue plasminogen activator. I have it on the next slide or one of the future slides. And it is endogenous, but it's really important to understand that TPA, your endogenous TPA, is not just getting released willy-nilly. It gets released when you have damage to your endothelial cells. So it would make sense, like if you cut yourself, you're gonna have damaged endothelial cells there. It's gonna release TPA. And it's important to understand that TPA needs to remain local, because that's actually one of the pathology states we're going to talk about later, is when you have TPA kind of acting rogue and it just goes wherever it wants. You don't want fibrinolysis activating where there's no clots. That's your bleeding risk, and that's why people with these bleeding disorders, a lot of the like primary fibrinolysis is literally that. It's just TPA acting rogue. So it's, again, really important to understand that TPA needs to kind of stay localized to where where the clot is, so it gets released by those damaged endothelial cells. Then we have urokinase. Urokinase is released from damaged urothelial cells. TPA is released from damaged endothelial cells. I have this on a future slide. But regardless, what they know so urokinase basically does what TPA does, but it gets released in very specific situations. So they can't tell you in vignettes, like this patient has a damaged urothelial cell. Where do you even find your urothelial cells? These are like, you find these in the kidney. So they can't say that. So usually what they do, and here's my little buzzword B for you, is like when you're doing vignettes and you notice like a patient's bleeding and you're like, that's odd. It could be because it's a guy that just had recent prostate surgery. The prostate is close enough to the kidneys where just moving everything around, to do the prostate surgery, you can actually damage the urothelial cells, and as a result, they can release urokinase. And then some fibrinolytics. So these are the actual medications we're going to talk about into like more detail later. But we have streptokinase, which is essentially just it's essentially TPA, but from beta hemolytic strep. So like your alpha strep, which is strep pyogenes, that can release streptokinase. So us as humans, knowing that bacteria are smarter than us, we're like, cool, we're going to use that and make a drug out of it. But the streptokinase, it's essentially just TPA, but they don't want to call it recombinant TPA because this is naturally occurring. So it kind of gets its own name. So it's streptokinase, it comes from strep, but it's basically it's basically TPA. Recombinant TPA, this is just basically, there's nothing really recombinant about it. I'm sure like how it's made is, but this is basically your artificial TPA. So this is where someone has higher than usual clotting risk or, someone's on like a high clot risk, you don't want to rely on their own TPA to be released to, break down these clots. So you can put them on some sort of recombinant TPA fibrinolytic therapy. So that's like your alteplase, your retaplase, and your tenecteplase. All right, so a little bit more on TPA, what it does. So this endogenous TPA, again, stands for tissue plasminogen activator, and it tells you what it does. So it's going to convert plasminogen to plasmin because it activates plasminogen. And again, this is damage released by damaged endothelial cells that line the blood vessels. Again, the goal is to kind of keep it localized to where you have that damage, because you don't want TPA just kind of going rogue and just going everywhere in the body. You really want to try and keep it localized. And it activates plasminogen. So what's plasminogen? Plasminogen is also something that's endogenous, but this is not released in certain situations. It's just always floating around. It's just in the blood, gets just there. And again, that's why it's bad if TPA goes rogue and goes elsewhere, because it can just activate the plasminogen that's already there. Okay, so it's always floating around in us all the time, and it's converted to plasmin via TPA. So to kind of visualize this, let's say we had a cut, and then, inflammation occurred, and we had primary hemostasis, and then we had secondary hemostasis. So now we have our secondary hemostasis. This is our clot. So this is your factor 13 stabilized, cross-linked, insoluble, D-dimer, covalent bonded clot. So what happens is, here's plasminogen. Again, it's always kind of floating around. Here's your endothelial cells lining the blood vessel. So now there's going to be damage from the blood vessels are going to be, the endothelial cells lining the blood vessel are damaged here because there's this massive clot there. It's disrupting it. So it's going to release TPA. And then what's TPA going to do? It's going to go to plasminogen and convert plasminogen into plasmin. This is why it's called plasminogen activator. It's activating plasminogen into plasmin. And what does plasmin do? Plasmin basically goes into the clot, and then it breaks it down. So plasmin breaks down the clot. We'll go into that in a little bit more detail. But this is essentially fibrinolysis. Okay, so more on plasmin. Again, highly regulated. This is really what I'm just keep trying to say over and over again. We do not want plasmin free floating in the blood. So again, we don't want TPA released where it shouldn't be released. And so kind of that's, again, we really want these things to be working right at the level of the clot, or that's when you start getting pathologies. So like DIC or primary fibrinolysis, that's where those guys start to pop up, when you have a pathologic plasmin production, essentially, which is usually because TPA is getting released more than it should, or it's going rogue, or it's going on its own, or whatever. All right, so what does plasmin do? Plasmin basically is going to break the clot down, so it doesn't just turn into like a big star. It breaks it down, and it breaks it down into two things. They're called fibrin degradation products, so FDPs, as well as D-dimers. So fibrin degradation products, another name for this is, you might actually see this written as fibrin, oh my goodness, and then like parentheses, ogin. So like fibrinogen degradation products with the parentheses there. And this is their way, when you see it written like this, as saying like you're going to get breakdown of fibrin, so that cross-linked, that final clot, as well as you're going to get breakdown of fibrinogen. So this is just them combining and not calling it like fibrin and fibrinogen degradation products. They just made one word out of it. So you get breakdown of both fibrin and fibrinogen, the monomer, the gel, you get breakdown of everything, okay? So it's another name that you can see for this, and you'll sometimes see this in vignettes as well, so just wanted to put it here so you'll know what it is. You can also see them called fibrin split products, because it's like fibrin getting split, broken down. Cool. All right, so breakdown products of fibrin monomers, gel, clot, and the only thing that fibrin degradation products can tell you is that plasmin is active. That's the only thing. So think about it in terms of like, if you have positive fibrin degradation products and you're like, okay, does this patient have, what pathology do they have? And you're like, I don't know. The only thing that the presence of these FDPs tells me is that plasmin is active for some reason. Plasmin is breaking down fibrin, fibrinogen, the monomer, the gel, everything. But the only thing that the fibrin degradation products though are not the D-dimer, like the D subunit. So you don't get breakdown of the covalently bound D units between the fibrin monomers. And I have a visual to help you kind of visualize this, but Fibrin degradation products is just everything basically except your D-dimers, essentially. But it's a breakdown of everything. Versus a D-dimer test. So again, you can order a D-dimer, you can order a fibrin split product or fibrin degradation product. You can order all of these lab tests. Fibrin degradation products just tells you like, yeah, plasmin's active, it's doing something. It's breaking down fibrinogen, fibrin, the gel, whatever. But D-dimers, this straight up tells you like, yes, I'm breaking down the fibrin clot. My factor 13 stabilized fibrin clot. I know it for sure. So the reason people say this is the best measure of clotting and fibrinolysis is because basically the first thing it tells you, so one thing that a D-dimer tells you, like having a positive D-dimer, certainly there's a clot that's formed, because again, that's the only way you get a D-dimer, right? The only way is that thrombin is activated, so 2A, thrombin's activated, it's converting fibrinogen to fibrin, and factor 13 are active, because that's the only way you get the dimer, the covalent bonds between the D subunits, which is how you get a D-dimer. This is only pretty much done by factor 13. But to even get to this point, we need thrombin to be active so that I can actually make a fibrin gel that's capable of monomer, making the gel, right? Thrombin helps make the monomer that's capable of making the gel before 13A can come in and cross-link it covalently with the covalent bonds. So that's the first thing that a D-dimer tells you. Like, one, we absolutely had a clot. So we definitely have a clot, a full clot. Full clot was formed. Factor 13 stabilized. The second thing it tells you is that certainly there's also clot breakdown occurring. So plasmin is active, because in order to get breakdown of that fibrin. So again, if you look at what plasmin does, it's going to break down the monomers, the gel, and the clot. Okay, so it's going to do it does everything. And again, just visualize this. Plasmin is breaking down this clot. But it's also, once it's active, it can break down, fibrinogen, the gel, etc. But it breaks down this clot. So we know from this one test that there was a clot occurring. And not only was a clot there, but plasmin is active, and it's breaking the clot down as well. So I'm sure you guys at this point have ordered D-dimers in your cases. You kind of hopefully are realizing that you can't use it to diagnose something definitively. It's not like a COVID test where if a COVID test is positive, you have COVID. That would be a positive test. You can really only use a D-dimer as a negative test. So you can't, if you have a positive D-dimer, that doesn't tell you automatically, oh, I have this condition automatically. That's not a positive test. Negative test is you can rule things out. So that's usually how D-dimers are used by clinicians. When I, again, was working in a hematology lab, if I had a positive D-dimer, if a D-dimer came up positive, I had to call the doctor right away. It was like one of those tests that you had to call the doctor. You can't just submit it in the computer system and wait for the doctor or the nurse or whoever to see it. You need to straight up call the doctor, be like, they have a positive D-dimer, because it's like they're clotting and they're fibrinolizing. That could be really, really dangerous. But it also helps for things like heart attacks, strokes, because heart attacks, strokes, those are clots. So once you get a clot, you're going to get breakdown of the clot, not right away, but those damaged endothelial cells are going to be releasing, start to break down. It's going to be releasing TPA. So if you get a positive D-dimer, that means there's a clot there and it's already started that fibrinolysis process. So again, just kind of showing you visually. So here's your cross-linked fibrin clot. So here's what plasmin can do. And like I said, plasmin can go back. It can break down fibrinogen. It can go back and break down the monomer. It can go back and break down the gel. But in terms of the clot itself, it can break this down into your D-dimers. And it can also break it down into your fibrin degradation products, which are just random combinations of the gels and whatnot. So it's there's no rhyme or reason. It's not like it's always going to be D and E and then E and D. It doesn't matter. It's just like a random conglomeration of the clot that's not the D-dimers. So FDP, so fibrin degradation products or D-dimers, when is it more important to use which one? How do you read it? How do you interpret it? So your FDPs, your fibrinogen degradation products, it basically only tells you that plasmin has degraded fibrinogen, fibrin, or insoluble cross-linked fibrin. That's all it tells you. That's it. Because if you think about it too, this insoluble cross-linked fibrin, you can still get FDPs from this. no D dimers, but you can still get it from this. So you can't rule it out. You can't rule out that it's breaking down a clot. So that's all it tells you. Plasmin is active. That's it. I only know that plasmin is active because there's breakdown and there's presence of these non-cross-linked things. So yes, it can come from a cross-linked clot, or it can just come from fibrinogen that's already just around. It's a clotting factor. It can just go, plasmin's active, it can just go break that down. We don't know if there's a clot there, but we know plasmin's active and it's just starting to break things down. So that's all I can tell you. Plasmin's active and it's degrading a bunch of stuff. And it's not saying it's degrading all of these things, it's an or, because all we see are the breakdown products. There's no dimers, there's nothing. A D-dimer, that tells you, so it does tell you that plasmin's active. So we know plasmin is active and it's degrading the insoluble fibrin. So we do know that that's happening. It could be happening with the FDPs, but it's definitely happening with D-dimers because that's the only way you get these D-dimers is from plasmin from a cross-linked clot. You can't have, there's no D-dimers in the monomer, there's no D-dimers in the gel, there's no D-dimers in the fibrinogen molecule. This only comes from the cross-linked fibrin clot, whereas FDPs can come from any of those things. But not only that, what's more important and helpful that the D-dimer tells you is that thrombin is active and you made a cross-linked insoluble fibrin clot. It was formed and it was stabilized. So formed is because thrombin was active and it converted fibrinogen to fibrin. Stabilized means factor 13 is active. And now we have that cross-linking because that's, again, the only way you get the D-dimers. Okay, so here's kind of just another visual. I think this is kind of confusing, but I do think it's helpful because you can see everywhere you can get the FDP. So here's fibrinogen to fibrin. Again, we're still the soluble form of fibrin. Here's thrombin. It does that process. And then from here, plasmin can break that down into fibrinogen or fibrin degradation products. Then we get activation of 13A. This also happens when thrombin's active. And then you can get your cross-linked fibrin. Now it's insoluble. And then plasmin can also break this down, and it's going to give you both your fibrin degradation products as well as your D-dimers. So again, if you only have a test for fibrin degradation products and you're only looking for fibrin degradation products, we don't know anything about thrombin. We don't know anything about it because technically, like, plasmin can just break down, it can just do this. It can just break down fibrinogen into fibrin degradation products. Here's plasmin. It can do that. So we don't know. Is that just fibrinogen floating around and then it gets converted because plasmin is just inappropriately being activated? Or do we have a clot? No idea if we have a clot. Absolutely no idea. That's what your D-dimer tells you. Your D-dimer tells you, like, yes, we absolutely have a clot because it's cross-linked and that's the only way you get the D-dimers. And yes, we also have plasmin that's activated because that's why we have D-dimers, because it got broken down. So then in terms of DIC versus primary fibrinolysis, how can we use all this information for test questions on DIC versus PF? So DIC stands for disseminated intravascular coagulation. This comes up all the time. There's lots of things that can cause DIC. Even like pregnancy can trigger DIC, which is terrifying. Don't love that. But it can. There's lots of things. So like if you're doing like questions in like repro and the answer is DIC, you're like, what? It could be because it's like so many things can trigger DIC within our bodies. It's actually kind of wild. But what DIC is everything we just talked about. We have both activation of your coagulation cascade and we're going to have activation of platelets. So that's the first thing that happens. So we're going to have activation of primary hemostasis and secondary hemostasis. So when that happens, what you want to think of is consumption. Because the platelets, so we get platelet depletion and clotting factor depletion because they're all going to make a clot, right? So the clotting factors, we talked about why they're zymogen. So if you're getting a clot, they're going to get depleted. Platelets, why platelets get depleted is because they are not, remember, your platelet count is a blood test. If your platelets are not circulating around in the blood because they went to go make a clot, that's going to be decreased. And that's why I say, like, with platelet, like with clotting disorders and things, think of consumption. Everything just gets consumed by this clot. Clotting factors do, platelets do, fibrinogen does, everything gets depleted by a clot. Okay, so that's why I say when you activate for both primary and secondary hemostasis, think consumption. Just we're consuming everything. So that's the first thing that happens in DIC. So we get these clots everywhere, which again, not great. We don't want clots everywhere in the body. But the second thing that happens, which is even worse, is we also get this subsequent activation of fibrinolysis. So we have clots everywhere, and then we have bleeding everywhere. We have breakdown of the clots everywhere. So really bad. So people call DIC just very easily excess clotting, excess bleeding, which sounds counterintuitive, but you get the clots and then they immediately start get broken down. So if you think about a typical patient presentation, it's going to be a patient that's hypercoagulable, but also bleeding. How do you treat that? I wouldn't know. You know what? I'd be like, yep, I'm not sure how to treat this. This is kind of ridiculous. Because it's like if you have clots everywhere, you can't give thrombolytics because then you're going to cause even more bleeding because it's already bleeding, but you can't give, something that can, help with clotting again. It's tricky. It's tricky to treat DIC. So what triggers this? So why would we have like widespread clotting and widespread bleeding? Usually it's sepsis. So sepsis, this is a lot of the times how people die from sepsis is from DIC. Trauma can do this. So even as actually that's why childbirth can trigger DIC because it's like very traumatic to the body and it can trigger DIC. And cancer can trigger DIC. Just things that they've noticed. Here is your buzzword B. I don't want you guys to see this term and automatically think it's DIC, but if you see this term, maybe like tune in and be like, oh, maybe this is DIC. I'm not going to lie, anytime I've seen a DIC question, they use the word oozing. But it's basically like oozing of blood from open wounds, IV lines, mucous membranes. Blood is coming out of every orifice. I'm sorry, it's very graphic. Eyes, nose, mouth, anus. If you have an IV in, it starts coming out of the IV line. If you have cuts, it starts coming out of the cuts. It's really gross. And they call it oozing because it's not like spouting out. It's just like ooze. It's just like flowing, very like, very sinister. It's very sinister. But that's kind of when you see oozing, kind of think like, okay, does this sound like a DIC presentation? So that's DIC. How do you tell the difference between DIC and primary fibrinolysis? Remember, primary fibrinolysis is kind of like, well, we didn't talk about it, so I don't know why I said remember, but primary fibrinolysis is essentially just plasmin being active without the clotting. Like we don't know if there's clots, we just know plasmin is like acting rogue. So that's your primary fibrinolysis. So it's generation of plasmin in the absence of clots. And again, the whole point of having plasmin get released is to break down these clots that we're making. So now it's like primary fibrinolysis is like we just have plasmin going around without clots everywhere. So you can imagine there's a bleeding risk there. So this is your inappropriate plasmin generation. Plasmin's going rogue. It's going to present similarly to DIC, but, and this is where they put the question, this is how they ask the questions. It presents super similarly. They're probably not going to say oozing unless they're trying to trick you. So just keep an eye out. But with primary fibrinolysis, you're not overclotting. You're not going to have depletion of platelets. You're not going to have depletion of your clotting factors. Nothing's going to be wrong with the PT-PTT. So these are kind of ways, that's probably pretty much the only way you can differentiate primary fibrinolysis versus DIC is you're not clotting in primary fibrinolysis. So you're not going to have depletion of everything that would be used to make a clot. And then primary fibrinolysis, if I had to just give it like one quick phrase, I would just call this excess bleeding versus DIC, that's excess clotting and excess bleeding. So here's like a chart. So it shows you the lab tests. And again, here are the two things that can kind of help you is DIC is going to be, you're going to have decreased platelet count. And then for D-dimer, you're going to have an increased D-dimer in DIC. Okay, because we're 100% making a clot and then we're breaking that clot down. Primary fibrinolysis, we don't know if we're making a clot. Actually, we're probably not making a clot. Actually, we're not making a clot. So platelets are going to be normal. So platelet count's completely normal because we're not consuming anything. And then your D-dimer is normal. We don't have cross-link clots. Like we don't. Fibrin degradation products in primary fibrinolysis, plasmin can go get those from fibrinogen or a fibrin gel or a fibrin monomer. It doesn't have to be an actual clot. So that's why the D-dimer is really helpful to distinguish between these two because it tells you like definitively there was a clot that was made, okay? And then you might see thrombin time here and there. Thrombin time is a measure of how long the blood's plasma takes to form a clot. Okay, so that's, if you look up what a thrombin time is, it's essentially the time to thrombin. So, or the time that thrombin takes to actually get you to get a clot. And I don't remember the reference range off the top of my head, but they're going to be increased. It's going to be increased in either. Yeah. Cool. Great. So just things to look out for. I actually put 2 case studies at the end to see. It's not easier than you think, but having those lab values really helps you differentiate between the two. It's because, again, remember, DIC, we get the clotting and the fibrinolizing. Primary fibrinolysis, we just have fibrinolizing. We don't really get clots that are being formed. It's just plasmin going rogue. But in DIC, it's plasmin going rogue, but also clotting going rogue. It's clotting everywhere. Okay, heme farm. So heme farm, we're going to start. So I give little descriptions of everything. So we're going to talk about anticoagulants. So anticoagulants is exactly how it sounds. It's a drug or a substance that prevents coagulation. Common indication. So like, why would you give an anticoagulant? It's intuitive, but we're going to talk about it. To treat or prevent, because how many people do you know? Like, how many people do you know that are on just anticoagulants prophylactically? So you can give it as a prophylactic to prevent conditions associated with any type of thrombus formation, like a DVT. So here is basically the clotting cascade, and then it has on here some of the anticoagulants that we're going to talk about. So I like these things for visual, like to kind of picture where these drugs are acting. UFH is unfractionated heparin. And then LMWH is low molecular weight heparin. Those are the 2 that I'm talking about. I don't talk about synthetic heparin or heparinoid. I don't really know what those are. But I'm assuming they do what low molecular weight heparin does. So that's good. We're going to talk about the one. Cool. All right, we're also going to talk about antiplatelet drugs. So these are drugs that inhibit enzymes or receptors required for platelet activation, aggregation, or thrombus formation. So your anticoagulants are working on the secondary hemostasis pathway. Your antiplatelet drugs are working on the primary hemostasis pathway. So here, we talked about some already, but we have like our irreversible COX inhibitors. It's going to be like aspirin, your P2Y12 receptor antagonists that we have talked about in the past, as well as your glycoprotein 2B3A inhibitors. There's like monoclonal antibodies nowadays. There's monoclonal antibodies against like 2B3A, which is cool. So that can happen. I also talk about NSAIDs in here a little bit because technically aspirin is an NSAID, and that's why they're showing you COX inhibition and the arachidonic acid pathway and whatnot. So we're going to do a little bit of a physio review, but it can't hurt. Cool. And then NSAIDs. So NSAIDs, the big key to remember with NSAIDs is that you have reversible inhibition of both COX-1 and COX-2. Remember, COX-1 is always endogenously on. It's always on. It's converting those membrane phospholipids to your arachidonic acid. It's like in your arachidonic acid pathway. It's converting your arachidonic acid down to like all the different stuff. So once you get arachidonic acid from your membrane phospholipids, COX-1 especially is going to break it down into all the various stuff. I have the arachidonic acid pathway somewhere in here. We'll go through it again. But COX-1 is always on. COX-2 is only turned on during times of inflammation. All right, so NSAIDs are reversible, so you can reverse them. And the main goal of your NSAIDs is to decrease prostaglandin synthesis. Well, not the main goal, but that's one of the goals of giving an NSAID is to decrease prostaglandin synthesis. A lot of the times you also want to decrease thromboxane synthesis. So here's your thromboxane A2. We also want to decrease that, especially in terms of antiplatelet drugs, because thromboxane's super, super big platelet aggregator and vasoconstrictor as well. So we want to stop that platelet aggregation. Yeah. And then, but we also want to talk about the decrease in the prostaglandin synthesis. Why do we want that? What's important about that? Exception to NSAIDs is aspirin is technically an NSAID. I looked this up because when I was in med school back in my day, like 3 or 4 years ago, aspirin was like, is it an NSAID? We're not sure. Apparently it is. Like apparently now, without a doubt, it is an NSAID. It just depends on the dose, and we'll talk about dosing. I'm pretty sure there's Anki cards on dosing, so it's not a bad thing to know. A lot of my friends always ask me, like, how much Advil should I take? And I'm like, because, like, it's always different depending on how much, or not Advil, I'm sorry, aspirin. It's like, I don't know. Just ask your doctor, right? But it depends on the dose because you can get different effects of, like, aspirin if you give low dose, intermediate dose, or, like, high dose. The high dose aspirin is kind of what you get your like NSAID effect. Regardless, so aspirin is a tangent on. It is an NSAID. We know it is, but the only difference is it's an NSAID that leads to irreversible inhibition of COX-1 and COX-2, so you can't reverse it, which isn't great. So that's the only difference. Associated pathologies, so NSAIDs in general have like their own little side effects that can be considered pathologies, and all of them are due to decreased prostaglandins. So having the decreased, you're not making prostaglandins anymore. So gastric and duodenal ulcers, this will always come up. I'm pretty sure like one of your SP patients during second year takes too much Advil. So when you ask about Advil, they're like, yeah, I take like 10 Advils a day. And you're like, what? Or like 10 Advils like at a sitting. And you're like, oh. And they come in with like stomach pain. You're like, okay, I think you're taking too much Advil. But that's why it's basically decreasing prostaglandins, and then you're not getting like mucous membrane mucus being formed in like the gastric and the duodenum. The stomach and the duodenum. So you can get ulceration. Get renal function impairment. This is a really good physio review, so we're going to do it on the next slide. But prostaglandins, remember that prostaglandins induce vasodilation of the afferent arterioles. So if you block prostaglandin production, you're not going to have as much vasodilation. It's going to kind of have a little bit more vasoconstriction, and that can actually lead to kidney failure because you can get decreased GFR, you can get decreased renal blood flow. Not good if you have, it's not like it's not having prostaglandins causes vasoconstriction. It's just the afferent arteriole is used to a certain amount of vasodilation, and now all of a sudden it's going to be less. So your kidneys are going to take a hit from that. And then other things to kind of remember about NSAIDs, which aren't really block relevant, but just they're life relevant, is avoid NSAIDs in your third trimester of pregnancy. I would just avoid NSAIDs in all trimesters of pregnancy, especially ibuprofen, because it can cause premature closure of the ductus arteriosus. And again, we're going to talk about it, but one of the prostaglandins, its whole role is to keep the ductus arteriosus patent not patent, but keep it open in utero. And then some drugs that are included in this group that we're going to talk about at least are indomethacin, aspirin, Celoxix, this one, and then acetaminophen. So these are the NSAIDs we're going to talk about, but there's more, of course. So this is what I was talking about. So here's normal. So normally your prostaglandins are going to cause vasodilation of your afferent arteriole. So you have, normal GFR, normal renal blood flow. We have a happy kidney. Then let's say you give an NSAID or you give some sort of inhibitor of one of the COX enzymes. Now it's not like there's vasoconstriction, but now we have just less vasodilation that we're used to. So now you're going to have, now there's less blood essentially coming into the nephron. So now the glomerulus is not going to get as much blood as it's used to getting, and that's going to reduce your GFR. And then your renal blood flow is going to go down and all that renal jazz that you'll get back to. But I did want to remind about this because this is a side effect of NSAIDs, is kidney failure. All right, so this is the arachidonic acid pathway with various types of drugs on here, especially your NSAIDs. I marked it up a little bit, but remember we have your membrane phospholipids are going to get converted to arachidonic acid from phospholipase A2. And then from here, arachidonic acid gets converted by COX-1 and COX-2 into your prostaglandins. And then from here, you can get your thromboxanes, your prostacyclin, and then your rest of your prostaglandins. On the other side, arachidonic acid can get converted by 5-LOX, which is lipooxygenase, into 5-HPEAT. And then you get leukotriene A4. And then from here, you get the rest of your leukotrienes, which also are helpful. And this is going to come up in many other blocks. So for example, the leukotriene receptor antagonist, this is going to come up in POEM block. You're going to learn about that in the POEM block, what these drugs do. So this pathway comes back like every block. It's a really important pathway. But regardless, here's where we're interested. We're interested in your COX-1 and COX-2. So from here, arachidonic acid, COX-1 and COX-2, again, only expressed during times of inflammation. But COX-1 is expressed constitutively, is going to form both prostaglandins and thromboxane. Thromboxane is a vasoconstrictor and a platelet aggregator. So that's one of the reasons we take a COX inhibitor, because we don't want that. And then some of the prostaglandins that you can get from here they have other roles, but it's more so like a side effect of taking an NSAID. Like these are some of the things that you can see, like the opposite of what their job is. So for example, prostaglandin E1, this is a vasodilator, and its normal role is to maintain the ductus arteriosus. So like, let's say we have a child with that's born and they have a congenital heart disease. So now the ductus arteriosus is like saving them because they have a congenital heart disease and they need their ductus arteriosus. You want to maintain it. You don't want it to close. You want to maintain that in that baby. So you would give a prostaglandin E1 analog, which the name is alprostadil. Okay, similarly, let's say we have a baby born and their ductus arteriosus remains patent and it doesn't need to. Like there's no reason for it. It's just taking a really long time to close. Guess what you can give? An NSAID. So usually they give something called indomethacin to close the ductus arteriosus in a baby that's otherwise healthy, doesn't have any heart defects. Other things, so prostaglandin E2, this is also a vasodilator. It's really good at so cervical ripening. I think that's funny. It sounds like the cervix is like a fruit that's like ready to eat. It's weird. But cervical ripening just means like you're getting the cervix ready to have a baby, essentially. You're like getting it like primed. Like when, not even to have a baby, it's like when you have a baby, it's like, here you go. It's almost like you're trying to induce labor by giving this, because it's really good at producing the mucus and whatnot. It's also really good for producing mucus within the stomach. So this is a really important one for, preventing, gastric ulcers. If you take NSAIDs, this is the one that is hurting you and causing the ulcers by not having this. And then you also have PGF2 alpha, which is a smooth muscle contractor. You pretty much only give this for if you have a mom that has postpartum hemorrhage, you can give carboprost, which is an analog of this, and it closes. It kind of stops the bleeding. And then over here, you also would stop producing PGI1 and prostacyclins, which are vasodilators, and epoprostenol. This is the analog given for pulmonary hypertension. On the other side, your leukotrienes down here. So we have leukotriene B4. Hopefully our ears perk up when we hear that, because now we have it's one of the neutrophil chemotactic agents. So leukotriene B4. And then we have other leukotrienes. These are the ones more so that are being targeted for the pulm, basically like antihistamine type thing. They're not antihistamines, but like your allergy, like an allergy and asthma like symptoms. You can give one of these leukotriene receptor antagonists to stop this. So C4, D4, and E4, these guys all cause normally bronchoconstriction and increased vascular permeability. So you would try to give an antagonist, block this, so you don't have bronchoconstriction, you have bronchodilation, and then you don't have as like leakiness within the vasculature. Cool. I think that's everything on here. But again, primarily I'm just showing you all of these things to show the size. I guess leukotrienes don't really have anything to do with NSAIDs, but we talked about at least leukotriene B4 in immuno, so it could come up. But at least in terms of this is the goal of kind of taking a COX inhibitor, is we don't want thromboxane A2, especially if you're using it in terms of like a hematology drug, but you're going to get all of these side effects by not having these things. You're going to have, instead of vasodilation, you're going to have more vasoconstriction, and then you're going to have not smooth muscle contraction, which you don't really need this for, but regardless, especially the decreased production of like the stomach mucus, which is helpful. Okay. So now the drugs. So now the actual drugs. So first we're going to talk about unfractionated heparin. So in that one image, it was like UFH. That's unfractionated heparin. This is just your normal heparin. And I know we talked about this already in one of the other sessions, but just for completeness, it's on here again. So heparin is an indirect thrombin inhibitor. So remember that it technically inhibits, it does many things, but one of the class is an indirect thrombin inhibitor, because thrombin is like the most important thing that it inhibits. But remember, the two that I at least deem most important is thrombin, so 2A, as well as 10A. So I think factors 10A and 2A are really important, that heparin is blocking. Because again, if you block these two, you're basically blocking the common pathway. And so again, it doesn't matter, extrinsic coagulation pathway, intrinsic, doesn't matter. They get to the common, and you're going to block you're going to block that from happening, because you're taking out two main players in the common pathway. But primarily how it works is, remember, it's making antithrombin 3 really potent. So it's really, really physiologically like activating antithrombin 3. When do you give this? It's acute MI. You give it mostly for acute MI, and the reason you give it for like an MI is because it's administered IV, so it works super fast. So that's good for someone that's potentially having a heart attack. So notes on this, it acts quickly. You assess it with a PTT, but remember, since we're taking out the common pathway, PT is also going to be prolonged, but just for whatever reason, use a PTT. The reversal, you use reverse. So if you take too much heparin, unfractionated heparin, you can reverse it, and you reverse it with protamine sulfate. It can cause HIT. So remember, your heparin-induced thrombocytopenia, and this is like usually like patients that are in a hypercoagulable state will get HIT. And remember, that's when heparin is acting as a hapten, and then it's causing removal, just like extrinsic removal of the antigen antibody complexes, the hapten antibody complexes. Use is associated with osteoporosis, which is just interesting. And then it can cause hyperkalemia secondary to hypoaldosterone. Hyperkalemia secondary to hypoaldosteronism. Yes. So then kind of going through this, why? Like, why do you get hypoaldosteronism? And the reason why is because heparin is a potent inhibitor of aldosterone production. So it, for some reason, blocks the production of aldosterone. It probably goes to, I don't know, it probably goes to like the adrenal glands. It is renally excreted. So you have to imagine like maybe it does something with the adrenal glands. I don't know. But regardless, it blocks aldosterone from being produced. And normally, remember, aldosterone reabsorbs sodium and excretes potassium. So now if you have hypoaldosteronism, you're not going to be able to excrete potassium, and you're actually going to get hyperkalemia, and then that's going to cause heart issues. Give me 1 second. Okay, hello, we're back. Had to take a phone call. I hope that actually, let me just make sure. Okay, it's recording again. Hopefully that actually stopped. You didn't hear my entire phone conversation, but if you did, whatever. But okay, so this can cause, we talked about this, it's great. All right, so remember, anytime you see hyperkalemia, you can have heart issues. So now this is a patient on heparin, and they have heart issues, and you're like, what's going on? And it could just be that they have hypoaldosteronism as a result of the heparin, and now they're having hyperkalemia from that. Next is going to be enoxaparin and dalteparin. I like enoxaparin better because it straight up, you have the XA in there, and it kind of reminds me of 10A. This is essentially heparin, but it's your low molecular weight heparins. So unfractionated heparin is like, heparin's a really big molecule. That's why you can give protamine sulfate to kind of like scoop it up, because it's just so big that you can just give anything, and then it's like, cool, like the opposite charge, it'll just grab it and be like, nice. But low molecular weight heparin is exactly what it sounds like. It's heparin, but now it's just low molecular weight. It's just smaller. So these guys mostly inhibit factor 10A, mostly, okay? And again, that's why I like enoxaparin at least, because it has XA in it, which is nice. That's your 10A. Dalteparin, you just have to remember that. But it's going to inhibit factors 10A, but also you're going to get thrombin inhibition, of course, it's heparin. But you also get 11A and 9A as well, okay? So you get, which again, regular heparin also inhibits 11A and 9A. It does do that. It's just mostly regular heparin is blocking 10A and 2A. Low molecular weight heparin mostly works through 10A. Actually, I'm curious with that one, with this guy. Yeah. Okay, cool. So even on here, so see on here, this amboss chart from a few slides ago, here's unfractionated heparin. It blocks 10A and 2A primarily, but then here's your low molecular weight heparin. It's only really showing blockage of 10A. And I think the reason like I even have this on here and like highlighted is because I think like you're allowed when you're doing questions to kind of think of it as only really inhibiting 10A versus unfractionated heparin inhibits 10A, 2A, and it does do others. It does, 11A, 9A. They're not as important, even in the amboss chart, they're not really on there. But those are the two main ones for heparin, and then this is the main one for low molecular weight heparin. All right, so when do you give low molecular weight heparin over heparin? It's actually easier to give logistically to give low molecular weight heparin. You don't need to, you don't have to, it's not IV, and 2, you don't have to monitor it. So heparin, you have to monitor with the PTT every however many days. Again, clinical questions, not my forte, but probably like every day, I'd assume you have to monitor, maybe multiple times a day. Again, don't know. But low molecular weight heparin, you don't have to monitor it. So it's easier for like the nurses, at least, and the doctors on the floor. Low molecular weight heparin also has a decreased risk of HIT. So maybe you have a really hypercoagulable patient. Maybe they have a history of having HIT. You might want to give low molecular weight heparin over heparin. And then studies comparing unfractionated heparin and low molecular weight heparin generally show that low molecular weight heparin is more effective and causes less bleeding. And I actually asked my babe, because she's a medicine resident, so she deals with, these drugs a lot. And I asked her, I'm like, when would you give, low molecular weight heparin over heparin? And something really interesting. So she said something really interesting. This is also renally excreted. So low molecular weight, it's also renally excreted just like heparin. But she said, for whatever reason, clinically, if you have a patient with renal failure, so straight up kidney failure, and they need heparin, you give them unfractionated heparin. Which to me, I was like, that sounds so counterintuitive because unfractionated heparin is huge and this is smaller. And she's like, yeah, I don't know the reasoning. It's just like, that's what it is. If you have a patient with renal failure, you have to give them unfractionated heparin. They're not a candidate anymore for low molecular weight heparin. So I just thought that was interesting. I tried to look into it myself. I couldn't really find anything. She said something about creatinine clearance, but I'm like, that's a step 2, level 2 kind of thing. They don't need to know that. But it was just something interesting that I wanted to include. And then another thing is that low molecular weight heparin is a lot more expensive than heparin. So you can kind of keep that in mind in terms of like the patient, what the patient would want to pay and whatever. All right, and then now we have our fondaparinux, these drug names, fondaparinux, rivaroxaban, and apixaban. So rivaroxaban and apixaban have the 10A in it. So I'm sorry, with enoxaparin, you just have to remember enoxaparin is your low molecular weight heparin. But rivaroxaban and apixaban, and then fondaparinux, I guess there's an XA in here somewhere. But these are your direct 10A inhibitors. So they do exactly what it says. They directly inhibit 10A. So there's no additional thrombin inhibition, nothing else like 11A, 9A. But all it does is it finds factor 10A and it inhibits it. From my knowledge, these are really good drugs. I know a lot of patients, I know that when a lot of patients need to be started on something outpatient, they give a 10A inhibitor. They don't give a heparin. So like my grandfather, for example, he's hypercoagulable. He has AFib. So he has AFib and he has something else, but he's on a 10A inhibitor. I forget what he's on. He's on one of these probably. And I know it's like, I remember the doctor saying, it's a good drug. It's low risk. It's an oral medication. You take it as a pill. And you don't need to monitor, so he doesn't have to go in. So this is really helpful for patients that are outpatient. My grandfather lives on his own. He's not in the hospital. He's not in a nursing home. So he's like, that would significantly impact his life if he had to go in every day to get monitored with a PTT. So that's really important to consider when you want to give a factor 10A inhibitor over something else, is the route of transmission and the fact that you don't need to monitor it. And then what's also even better is if you take too much of this accidentally, you can reverse it. So I don't know about the fondaparinux, but at least with rivaroxaban and apixaban, you can give something called andexanet alpha, andexanet alpha. You can give that and it'll reverse the effects, which is cool. So it's kind of like a little antidote for the 10A inhibitors. All right, next we have our bivalirudin, argatroban, and dabigatran. I feel like I used to know these, like back in the day. But these are your direct thrombin inhibitors. I keep doing that. 2A. Come on, Christina. All right, so these are your direct thrombin inhibitors, and thrombin is factor 2A. So what its mechanism is the same as your 10A inhibitors, is these are going to inhibit thrombin directly. When you would give this to treat heparin-induced thrombocytopenia. You can give this. I don't know if I probably meant like if a patient has it, you can give this in place of heparin. If I remember, I'll change it before I upload it. But you want to give this in case the patient develops HIT from heparin. You can give this because it essentially is doing what heparin does. But another cool thing about this is that it also does not require lab monitoring. And then dabigatran, you can reverse it with a drug called idarucizumab, which we learned is a monoclonal antibody. And it's humanized, ZU. Cool. So dabigatran's antidote is idarucizumab. Okay. Next is warfarin. We talked about it, but remember it's a teratogen. Another name for it is Coumadin. This is an anticoagulant that's administered orally, and its mechanism, and it inhibits gamma, and I put the symbol this time. So gamma, so in case you see, because I've seen this too in question like answer choices, this is the gamma symbol, gamma. So it inhibits gamma carboxylation of your vitamin K dependent factors 2, 7, 9, 10, protein C, and protein S. Specifically what it's doing is it's inhibiting this enzyme called VKOR, which is vitamin K oxyreductase. So it's not allowing that enzyme, it's not allowing VCOR to undergo the process of gamma carboxylation to make these clotting factors. And the gamma carboxylation process from this enzyme require vitamin K. It requires vitamin K. And then warfarin, as we talked about, is metabolized by the CYP450 system. Mainly the two members of this, and this is not for this exam, this is for boards because they ask about this stuff. CYP3A4, CYP2C9. There are Dirty Medicine videos on, like Dirty Medicine has a video on how to remember all these enzymes, a part of the CYP450 system, and like what roles they do. But this is in case you're keeping a list already. These are the two specific enzymes in the CYP450 system that break down warfarin. So when would you give this? So indications for this would be, if you're hypercoagulable or you have a thrombosis risk. And then some examples of that are like if you have an artificial heart valve or if you have just any sort of increased risk of DVT, pulmonary embolism, or AFib. It's also teratogenic, so remember you cannot give it to a pregnant mom. That's usually what they'll do. They'll put that in the question stem, and you can't give it. So it crosses the placenta, causes abnormal bone formation in utero. So remember, we talked about this with warfarin. It's a very, very slow onset. Like essentially it could be like 12 hours later. And the reason why is because it doesn't do anything to the factors that are already made. It goes to the liver and it basically stops that VCOR enzyme and it stops the production of new clotting factors. But there's still clotting factors out and about in the, in the blood. Doesn't do anything to those. So that's why it works super slowly. It has to actually go to the liver and stop the production. And remember, you always want to bridge. So you administer with heparin to combat the transient hypercoagulable state. If not, patient will get warfarin skin necrosis. And if you don't know what I'm talking about, I discussed this in a lot more detail in the secondary hemostasis video. So go look at that because I go into like bridging, why you need to bridge, and what's warfarin skin necrosis. And then you always want to assess warfarin with a PT. Again, it's just like someone just decided that. You look at heparin with a PTT, you look at warfarin with a PT. But remember, don't get got with that because warfarin and heparin will increase both PT and PTT. So both are going to be prolonged. And like I said, people, it sounds intuitive, but people always are like, no, warfarin, like PTT's fine, PT's prolonged. No, they're both prolonged because look at the factors that are inhibited, 2, 7, 9, and 10, and then protein C and protein S. But 10 at least is in the common pathway. And 2 and 10 are in the common pathway. So like you're going to knock out both your PT and PTT. How do you reverse it? So you can give vitamin K, but this is like long-term because again, we're knocking out this vitamin K dependent enzyme. So you just give vitamin K, here you go. But that's like long-term, it takes a while to work. So what you want to do is you want to try and replenish the clotting factors. And so what you want to look for is giving something like FFP or cryoprecipitate. That's immediate. That immediately replenishes your clotting factors. Or you can give prothrombin complex concentrates, which is called PCC. That's also very quick, very immediate. And then it kind of bumps your clotting factors back up. Okay. And then so this is my little again, the CYP450 drugs was so big on STEP for absolutely no reason at all. And like I said, I wish I started paying attention to the CYP drugs like early on in year 2. So here's my attempt to have you guys do that. So you want to pay attention to, and this is just good to realize, like for drug-drug interactions, if you are on a drug that induces CYP450, so like not even thinking of drugs, but like I'm on a drug that increases the quickness of how quickly CYP450 works. Warfarin is metabolized by CYP450. So if you're on a drug and it speeds up CYP450, those enzymes, it's going to break down warfarin quicker than you want it to be broken down with the dose you picked. So now the patient's at risk for clotting because now it's like they're not protected for as long as they thought they were going to be because it's gone out of the system quicker. Conversely, So those are your patients. If you're on a drug that induces CYP450 now, and they're on warfarin, now your patient's a clotting risk. If you are on a drug that inhibits CYP450, now it's going to be the opposite. It's not going to metabolize warfarin as quickly as you need it to. So now it's going to stay in the system longer than you want it to. And now you're a bleeding risk. So some examples, again, this is going to be for boards primarily, but I mean, it's good to know. It really is good to know. It might come up. So like I said, if you have a drug that's going to so if you are on another drug, and I probably should have put this, well, regardless, some of the interactions that can occur is you decrease warfarin's anticoagulant effect, which sounds confusing. You kind of have to think about it. So you're decreasing its anticoagulant effect. Now the patient would be clotting too much. So those are your inducers, your CYP450 inducers. There's all sorts of mnemonics. Like I said, Dirty Med has some, but it's like a bunch of drugs that you probably haven't even covered yet. But some weird ones are like ginger, licorice, alcoholism, so like chronic alcoholism, St. John's wort. Oh my gosh, everyone in like their 60s and above was on St. John's wort at one time or another. So that's why I'm positive that's still here. Something interesting is it's nothing to do with CYP450, but you can counter the effects of warfarin by having too much vitamin K. Warfarin's trying to knock out vitamin K, and that's why you don't make the vitamin K dependent factors, 2, 7, 9, and 10, protein C, protein S. So you can actually counter its effects if you have just so much vitamin K in your system. So you just have like kale at every single hour, spinach at every single hour. So too much vitamin K can also reverse warfarin's effects. So you get this clotting risk accidentally. And then if you increase the anticoagulant effect, now you're bleeding too much. These are your CYP450 inhibitors. So some drugs on here, here's isoniazid. Isoniazid I feel like comes up in every single session. So isoniazid's here. Binge drinking. So that's what I thought was interesting. Chronic alcoholism is an inducer of CYP450, but binge drinking is an inhibitor, which is interesting. Other drugs. Here's chloramphenicol. Remember that causes aplastic anemia. That's like your classic aplastic anemia drug question. Again, other drugs you probably haven't covered yet. Some antibiotics that you should be working through a little bit. Grapefruit juice. I think I put this on here in red because I feel like they might have asked this on my exam. I just remember grapefruit juice being like on an exam that I had taken. I don't remember if it was for this exam, but I remember like the answer was like grapefruit juice, and I'm like, what? Like, why is that the answer? But I think so. If that's the case, then if you have grapefruit juice, it inhibits CYP450 for some reason. So if you're also on warfarin, and I actually think if you are on warfarin, it literally says don't have grapefruit juice with this. And I think that's why it inhibits CYP450, so now you'd be a bleeding risk. Another thing that can happen is you can basically increase its anticoagulant effect accidentally. Same with like having foods rich in vitamin K. What if you have chronic antibiotics? Remember, your gut bacteria produce vitamin K. So now if you're on chronic antibiotics, you're taking out your gut bacteria. They're not producing like physiologic levels of vitamin K. So now you're basically increasing the anticoagulant effect. You're doing warfarin's job for it, essentially. So keep that in mind as well. Okay, next is indomethacin. So indomethacin, this is your NSAID. It's a non-selective COX-1, COX-2 inhibitor, so it inhibits both. It is reversible because it's an NSAID, and it's anti-inflammatory because it's an NSAID. And I don't even know if I said what NSAID stands for, but it stands for a non-steroidal anti-inflammatory drug. I think that's what the D is. But that's what NSAIDs are. They're non-steroids, and they're anti-inflammatory. So that's duh, right? So mechanism, it's anti-inflammatory. Thank you. And it does work through NF-kappa B. I didn't point it out in that image, but if we do go back really quick, here is NF-kappa B. And the NSAIDs, that's what you're basically trying. That's actually a glucocorticoid. So glucocorticoids directly inhibit NF-kappa B. But NSAIDs do have this NF-kappa B component, which is how it gets its anti-inflammatory effects. But the mechanism question is glucocorticoids directly inhibit NF-kappa B. NSAIDs just kind of do it indirectly because they're inhibiting COX. Okay, great. And then indication. So usually you only give indomethacin to close a PDA in a baby. And remember, it's doing this by decreasing the prostaglandin production. So this would be in like a baby that doesn't have a heart defect and the ductus arteriosus is remaining patent for some reason. Now you can close it by giving an NSAID. And usually they give indomethacin. The reason I wanted to talk about it here, even though it really doesn't have anything to do with Heme/Onc, is that one of the adverse effects is aplastic anemia. So if you remember from the mnemonic I gave you guys for the drugs that can cause aplastic anemia, Indomethacin is one of them, and that's what it is. It's an NSAID, and it can cause aplastic anemia, and it's really highly associated with GI ulcers. And just an interesting note about indomethacin is one of the only lipophilic drugs that can cross the blood-brain barrier. Cool. Next is aspirin. So aspirin is an NSAID as well as an anticoagulant. So it's an NSAID anticoagulant, and that's because of the dose. You can play around with the dose, and it can act as an NSAID in one dose, and then it can act as an anticoagulant in the other. Mechanism, it's going to inhibit both COX-1 and COX-2 irreversibly. So this is the only NSAID that works irreversibly. And sometimes they'll actually ask, what's the mechanism of aspirin's irreversible inhibition of COX-1 and COX-2? And if you're sitting there like, no one's going to ask that, you're going to get a URL question on it and be like, that's absurd. And then it's going to come up on boards and you're going to be like, great, I know this. But I'm telling you, it works through acetylation. So it's going to acetylate COX-1 and COX-2, which renders them inactive, but not only renders them inactive, it irreversibly inactivates them until it kind of, flushes out. Indications are going to be dependent on the function, and the based on like what you want it to do depends on the dose. So what I've said, so low aspirin is less than 300 milligrams per day. So this is giving, and again, dosing I feel like does come up every now and then. That's why I tend to include them here. But just know the lowest dose aspirin, this is going to be your antiplatelet effect. So that's your decreased platelet aggregation. This is like your baby aspirin. Hopefully you guys know never give aspirin to a baby. But that's basically what baby aspirin is. It's very, very, I actually think baby aspirin is even lower than 300. I think like baby aspirin is like 100 milligrams. It's really low. But yeah, we're going to talk about that, but don't give aspirin to a baby, even though it says baby aspirin. They're not supposed to ever get aspirin ever. But anyway, intermediate dose is 300 to 2400 milligrams per day. And again, it's per day, not per dose. So remember when you're telling people like, take 4 pills. Like if you take 2 pills of this, that's 200 milligrams. So that's why you kind of have to stagger it. Usually it's 4 hours and then you can take your next dose, but you don't want to exceed in 24 hours. So that intermediate dose, this is your antipyretic, so fever reducing, and analgesic, so your pain reducing effect. And then your high dose, your 2400 to 4000 milligrams per day. This is how you get your anti-inflammatory effect of aspirin. Other indications, you can give this in setting of acute MI. You can administer it in a chewable form because it works quicker. You can also treat Kawasaki disease. So Kawasaki disease, you'll learn about it next block. It's a vasculitis. And so it's just good to know. It's interesting because Kawasaki disease happens in children. And it's the only time you ever want to give aspirin to a child is if the child has Kawasaki disease, because it completely reverses it. So it's like worth the risk of giving aspirin to a child if they have Kawasaki disease. So if you get to it next block and you're like, why the heck are we giving aspirin to a child? It's because of this. It's the Kawasaki disease. But if you give an aspirin to a child and they don't have Kawasaki disease, they just have a normal viral infection, you want to try to bring down the fever, you can get Ray's syndrome. And then Ray's syndrome, just very quickly, is associated with aspirin use for viral illness in children less than 19 years old. And usually how you can tell this in vignettes is you're going to have like a child, maybe usually they're like 8 or 9, and they have some sort of viral infection. So like 3 to 5 days before these new symptoms, you're going to give them, they're going to sound like really sick. They're going to sound like they have an upper respiratory tract infection. And then you're going to give them aspirin. And then this is going to happen. So what Ray's syndrome essentially is a hepatic encephalopathy. So they can get severe vomiting, altered mental status, neurologic symptoms, as well as liver failure. So we have the hepatic part, and then we have the encephalopathy part. And just a mnemonic to kind of remember that, it's never rainy, Ray, in Chile. I guess it doesn't rain in Chile, but Chile is an acronym that stands for coma, hepatomegaly, hypoglycemia, history of viral infection, liver failure, and then encephalopathy. So encephalopathy, think of things like lethargy, delirium, coma, seizures, things of that extent. Okay, cool. You can co-administer aspirin with ADP receptor blockers. And so when we get to ADP receptor blockers, I'll, have that mentioned again, but remember, aspirin has nothing to do with PT-PTT. It only is going to affect bleeding time. And then you actually may cause a pseudo allergy due to increased leukotriene synthesis. So if you do, so since you're taking out COX-1 and COX-2, if you can think back to the arachidonic acid pathway, you're not making prostaglandins anymore. You're going to get shunted to the 5-lipoxygenase pathway, the 5-LOX pathway. And what that pathway makes is your leukotrienes. And remember, leukotrienes cause, some cause neutrophil migration, but some of them cause bronchoconstriction, leaky vasculature, like things like that. So it can be like you take aspirin and then all of a sudden you have like allergy symptoms, like you're sniffly, you have asthma symptoms, it's like you can't breathe. It's really weird. It's because you're shunting from prostaglandin synthesis to leukotriene synthesis. And in some patients that can present as like a pseudo allergy, like kind of like an allergy. Adverse effects, GI ulcers, it's from the NSAID of basically blocking prostaglandin synthesis, and then tinnitus, so the ringing in the ears. And then note, this is just an interesting note, it can actually displace thyroid hormones from the binding proteins and should therefore be avoided in patients with hyperthyroidism. So there you go. If you have hyperthyroidism, don't take aspirin. Toxicity. This is usually what they ask about with aspirin. So remember that aspirin causes both a respiratory alkalosis and a metabolic acidosis. So it causes like the two exact opposite things that the body can have in terms of acid base. And what's interesting, I didn't put dates, like early is like, however many minutes or whatever, and late is however. I still, to be completely honest, don't really know what they mean by this. I think I learned this when doing like UWorld questions. Whenever, kind of like the idea is when you're doing UWorld questions and something disagrees somewhere, like there's a source that it's a discrepancy somewhere, you always go with UWorld. That's kind of like the idea. So I feel like I learned this topic from doing UWorld questions. It was like I did a question and it asked, patient takes aspirin, what's their acid base status? I kind of saw like, oh, this is 12 hours later. And the answer is like, high anion GAP metabolic acidosis. So clearly 12 is late. So you can kind of learn it that way. I think early, I tend to think of like soon after you take it, within like a few hours. That's early, versus late is like later in the dose, I believe. I really struggled with this idea. I didn't want to put, and it's really hard to find like a consistent source online. So I would just go with UWorld, but at least understand what's happening. So early on, what aspirin is doing, so aspirin's a salicylate, right? And remember, salicylates are going to, well, not remember, but salicylates stimulate the respiratory drive because they go to the medulla and they stimulate the respiratory center. So basically they're making you breathe quicker. So if you're breathing quicker, so if you're like, kind of like you're hyperventilating, you're blowing off CO2, which is technically an acid in acid-based stuff. So if you're blowing off, you're removing an acid, you're going to have alkalosis. And it's a respiratory cause. So salicylates at first cause you to breathe faster, hyperventilate a little bit, respiratory alkalosis. And at this state, if you're having symptoms from this, like bad symptoms from this, you can use activated charcoal and it'll basically absorb the alkalosis, essentially, like what's causing the alkalosis. Later, you have the high anion GAP metabolic acidosis. And if you guys can remember from your mud piles mnemonic, that's going to be salicylates late. So it's like salicylates late, and that's what it means. It's like aspirin, but it's late aspirin. It's not early, because early aspirin is respiratory alkalosis. But later, it's going to give you a high anion GAP metabolic acidosis. And if you do Winter's formula, TBT to Winter's formula, you'll see that there's usually a concomitant respiratory alkalosis. So it's still there. But overall, you're getting a high anion GAP metabolic acidosis. And how do you treat that? You can alkalinize the urine. So alkalinizing the urine is basically giving sodium bicarbonate. I think that's what that is. I believe that's what that is. But you give some sort of base, which is super high pH, and it's going to basically pull aspirin out of the CNS. And when you're doing this, it's promoting its secretion out. You're trying to get rid of it out of the system, because again, there's nothing really to reverse aspirin. It's irreversible COX inhibition. So you have to kind of give things like treatment and reversals the symptoms. So like activated charcoal is going to absorb what's causing the alkalosis. Same thing here, alkalinizing the urine, you're trying to just remove the aspirin quicker. Okay, we have celecoxib, I think. This is also an NSAID anticoagulant, but a lot of the times it's given for its NSAID effect. This is a selective COX-2 inhibitor. Again, it's usually given for its NSAID effect and not its anticoagulant effect, because it really is blocking a particular prostaglandin, because of this whole selective COX-2 inhibitor idea. So you would really only give celecoxib if you have times of inflammation. You could give this. So indications: inflammation, so arthritis, acute pain, menstrual cramps, discomfort of some sort, something like this. So it's like a stronger, it's like a more selective Advil. So it's like, I have very specific pain and it's related to inflammation. It's like, cool, take celecoxib or whatever. An adverse effect, though, which I think is hilarious, is you have an increased risk of thrombosis, which is very ironic because it's technically an anticoagulant, and then you have a risk of thrombosis. But the reason why is because you're basically inhibiting PGY1. No, that's not what that says. PGI2. So you're inhibiting prostaglandin I2 without concomitant inhibition of thromboxane A2. So it's like you're taking out one part of that pathway, the COX pathway, without taking out thromboxane A2 specifically. Thromboxane A2 is a very potent vasoconstrictor, platelet aggregator. So in some patients, you can get this increased risk of thrombosis. But I just think it's ironic because it's considered an anticoagulant. Next is acetaminophen, which is Tylenol. This is antipyretic and analgesic, but Tylenol is not anti-inflammatory. Tylenol is not an NSAID. Okay? Technically. It doesn't have that I think it's considered like in the NSAID group, but it is not anti-inflammatory. It doesn't have that effect. It still inhibits COX. It's a non-selective reversible COX inhibitor. So in that way, it's like an NSAID, but there's no anti-inflammatory effect, which very confusing, but it is what it is. So when do you give Tylenol? You usually give it to like lower fevers. That's essentially why. It's a really good antipyretic. So like a child with a viral infection, you can't give aspirin. Let's give acetaminophen. Let's give Tylenol. The only thing with Tylenol is that it can cause liver toxicity. So you don't want to take it when you're like drinking too much alcohol, because then you're like kind of taken away from acetaminophen's metabolism, and because it's got to work on alcohol and so forth. So watch out with the liver toxicity. Next, thienopyridines. So this is clopidogrel, ticagrelor, prasugrel. These are P2Y12 receptor inhibitors. P2Y12 is an ADP receptor, so sometimes they're just called ADP receptor inhibitors. But I would know ADP's receptor is P2Y12 because it comes up. Mechanism, basically what it's going to do is it's going to prevent expression of 2B3A on platelets. So it's going to block that. Is that what it's doing? Hold on. I'm gonna look at that. I will look at this slide. So if this says this when I upload this PowerPoint, I'm gonna look at this because I'm pretty sure it just blocks. Actually, we have the mechanism chart, don't we? Where are you? Okay. Yeah, so P2Y12 inhibits ADP receptor right here. Oh, which is putting 2B3A on the surface. I see. So I guess it is doing this indirectly. Time to brush up on some of this stuff, huh? Yeah, so by binding to the ADP receptor, by binding to P2Y12, you're not allowing the expression of 2B3A to be put on the surface, and that's what that one image showed. Indication, so it's going to reduce risk of future cardiovascular events, but it has no effect on claudication symptoms in peripheral artery disease. So you will go into a little bit more peripheral artery disease and claudication. I probably should have taken this out, but like I said, these like farm slides are more so for boards. But you'll go into what claudication is, peripheral artery disease in the vascular chapter of your cardio block. You have to do the vasculitis chapter. And all things vascular pathology, I should say. So you'll go into that. Claudication, that was just basically like pain with walking and stuff. It's because you have peripheral artery disease. And then you can also use this in dual with aspirin. So I had that on the aspirin slide, and it prevents coronary. So it's also, when you use that in dual with aspirin, you're technically preventing coronary stent thrombosis. So if you get a stent in, you want to be really aggressive because you don't want platelets to be sticking to that stent. But again, they do not reduce the symptoms of claudication. I feel like I put this on here because there's probably like a lot of UO questions. Like I was between aspirin or P2Y12 or like even another drug, and it was like the patient had claudication, which is pain with walking because of their peripheral artery disease. Like, what's the best drug to give? You don't want to give this because it doesn't do anything with claudication. I think there's another drug that you can give, and it's like known to reduce symptoms of claudication. All right, adverse effect is TTP, so you can get that. So remember that there's many causes of TTP. So you can get that from this. You can get that thrombocytic purpura. And then ticagrelor only is going to be reversible. So you can reverse ticagrelor. I guess knowing the drug that you can reverse it with is not important, but a unique side effect of ticagrelor is dyspnea. So you can have like shortness of breath. Next, ticlodipine. This is also an ADP receptor antagonist, and an adverse effect here is TTP, but a really strong association with TTP. Interesting, cool. So all the ADP receptor antagonists are going to cause TTP or might be associated with TTP, but it seems like ticlopine is a very strong association with TTP. So this might be just like a side effect to pay attention for. It might sound like TTP, and then you're like looking for like the child trying to eat the hamburger. You're like, where's the child eating the hamburger? And instead it's like a guy that, he goes on ADP receptor therapy, and you're like, wow, that's what's happening. But it could just be, it's a side effect of the medication. Granulocytopenia, especially neutropenia. So granulocytes, neutrophils, basophils, eosinophils. So you can have all of those decreased, but especially your neutrophils decreased. This one also does not, it's an ADP receptor inhibitor, so of course it's also not going to reduce the symptoms of claudication. Okay, next, abciximab. This was on my boards, and I remember like being like, wow, of course they ask this out of all the, antiplatelet drugs. But I'm telling you, they loved immuno on my boards. I just got very lucky on STEP. I got very lucky. I had a lot of immuno on my STEP. So this is the drug that they asked about in terms of antiplatelet drugs, abciximab. And I think that's how you say it. But it's a monoclonal antibody, MAB, against 2B3A, so glycoprotein 2B3A. So of course, remember 2B3A is what's responsible for platelet aggregation, so making the platelets come together. 1B is associated with adhesion to like the exposed collagen. And VWF, of course, it needs VWF to do that. But here you have 2B3A, your platelets can't aggregate. So obviously its mechanism is antiplatelet, it prevents aggregation. So when would you use this? You would use this in patients undergo PCI, your coronary intervention therapy. It's like a type of therapy. It's basically putting in a stent in order to prevent ischemic complications. So you can use aspirin and a P2Y12 receptor blocker, or you can just give abciximab, this 2B3A, because again, platelets, even if they stick to the stent, they're not going to aggregate, so you won't get clot formation, which is good. You can also give it in patients that have unstable angina. Kind of, I guess, the same reason. If you already have a blockage, you don't want to further it and then get a heart attack from that. Adverse effect is thrombocytopenia. That makes sense. You have a monoclonal antibody against a platelet, you might get thrombocytopenia from that. These guys, so abtificabtide tirofiban. These are also 2B3A receptor blockers, adverse effect thrombocytopenia. It doesn't seem like there's much else about this. I think it's more so if you see these names, you'll recognize them as being 2B3A receptor blockers in addition to abciximab. Okay. This one, yeah. So dipyridamole and cilostazol, these are phosphodiesterase inhibitors. So not prostaglandin, phosphodiesterase, so PDE. Dipyridamole is a PDE, I'm just gonna say it, phosphodiesterase 5 inhibitor, and then cilostazol is a phosphodiesterase 3 inhibitor. And a lot of the times with phosphodiesterases, they like that physiologic mechanism because they're it's G protein coupled. And we talked about this very briefly in cardio with some of the other phosphodiesterase 5 inhibitors. You can give it for cardiopulmonary pathology states, but these two you can give them for certain things in the hematology world. So what they're going to do is they're going to increase cyclic AMP, So when you increase cyclic AMP, this tells me that this is coupled to a G protein, because increasing cyclic AMP is going to inhibit platelet aggregation. So it's probably going to block platelet aggregation. And then in addition to that, that increase in cyclic AMP is going to cause direct arteriolar vasodilation. So I think this is why you give it for like the cardiopulm stuff. You get vasodilation from it. But in this instance, you get these phosphodiesterase inhibitors. You get inhibition of platelet aggregation, one, and you get vasodilation. So what does this sound good for? Claudication and peripheral artery disease. So basically leg pain with walking in peripheral artery disease, where the arteries essentially are going to be narrow. Now it's directly causing vasodilation. That's going to help you with those symptoms, those painful symptoms, if you already have decreased arteries. Adverse effects: facial flushing, abdominal pain. Remember your phosphodiesterase inhibitors, you can get that facial flushing from it. All right, thrombolytics. So we did already touch on these thrombolytics, so hopefully this won't be too much longer. But thrombolytics are essentially when you're pharmacologically breaking down a clot that's formed in the vessel. We talked about this. Why would you give a thrombolytic? A STEMI, an ischemic stroke, massive pulmonary embolism, severe DVT, acute limb ischemia, something like that. Complications of giving a thrombolytic: bleeding, too much bleeding, right? And sometimes what's not great is I believe you learn, I forget when you learn this, but you'll learn about like stroke assessment, like patients that come. So most strokes are ischemic strokes, right? It's like a clot and then it blocks blood flow to the brain, and then that portion of the brain dies, and that's like your stroke. Some strokes are hemorrhagic. I think it's like, I don't even want to guess, but I think it's like 90% are ischemic. That's probably not right. And then like 10% are hemorrhagic, but hemorrhagic strokes are like a lot less. Like it's a lot less percentage of strokes are hemorrhagic. So there's like this protocol where it's like, how long after someone has a stroke can I, like where I can give a thrombolytic and feel okay about it. It's like, I don't know because if you give a thrombolytic and a patient already has a hemorrhagic stroke, which is bleeding into the brain, and that's what causes the stroke, now you're going to give a thrombolytic, it's going to cause even more bleeding into the brain. So I believe when we still had Dr. Scally, who was our director before Dr. Genora, he taught some of our HMP sessions for this block. He was an ER doctor, so he dealt with like stuff like this a lot. He would go into I believe he discussed when you give thrombolytics versus not for different types of strokes, but I'm off topic. But just keep in mind that you can guess wrong. Like you think it's an ischemic stroke, especially in vignettes, like they guess wrong. They think it's an ischemic stroke, they give a thrombolytic, and then it makes the stroke worse. And you're like, ooh, this is probably a hemorrhagic stroke. Or they have an ischemic stroke, but now you give too much of a thrombolytic. Now you can get intracranial hemorrhaging. So you can get bleeding directly into the brain. And the reason it's happening in the brain is because there's just a lot of blood vessels in the brain. It's easy to kind of pop them accidentally. Okay, cool. So this is what we talked about earlier. So we did talk about, your recombinant TPAs, so retroplase, tenecteplase, alteplase is another one. Urokinase, this gets released from your uroendothelial cells, and then streptokinase, this is naturally occurring. They're all doing the same thing. They're all doing the exact same thing. They're converting plasminogen to plasmin. And so you can have this happening too much. This can be happening just roguely. And that's when you get your fibrin degradation products, either from fibrinogen or that fibrin mesh. And then sometimes if you have an actual clot, you can also get the D-dimers from that. All right, so alteplase, retroplase, tenecteplase, these are your recombinant tissue plasminogen activators. They activate plasminogen, so it's going to convert plasminogen to plasmin. Indication: clots. That's the best I can do. So you give it for when you want to break down a clot, or someone's not even hypercoagulable. I'm pretty sure you just give this when someone has clots. These indications are pretty much the only time you give it, because you can give anticoagulants prophylactically. This is when you know that there's a clot. These can cause elevated PT and PTT with no effect on platelet count, because again, you're breaking down a clot. Cool. Streptokinase, this is also a fibrinolytic. It does the exact same thing as the last two or the last three, but so same mechanism, same everything. The only difference is this is naturally found in your strep species. So this is just a naturally occurring one. It's not one that you're making artificially, like alteplase or retroplase or tenecteplase. All right, and then urokinase, I brought it up again, not a drug, but remember urokinase, it basically does what TPA does, so it converts plasminogen into plasmin. And then here's my little plug again. This is really the only way they're gonna tune you guys into urokinase release. Is patient just underwent prostate surgery and is now presenting with bleeding, normal platelet count, elevated PT-PTT. So your antifibrinolytics, so that's a kind of sounds like a confusing word, but it's basically like what happens if you give too much of a thrombolytic, am I screwed or can I reverse it? So you can give one of these things down here to reverse the thrombolytic effect. So the two main ones that like actual drugs that you can give is aminocaproic acid and tranexamic acid. So these two are really good at basically reversing fibrinolysis. And how these guys work, so aminocaproic acid, tranexamic acid, they competitively inhibit plasminogen activation. So TPA is activating plasminogen. This is doing the exact opposite. It's blocking plasminogen activation. So that's good. You can also give FFP or cryoprecipitate, things with like lots of clotting factors in them. So if you actually give too much of a clot buster, you can just try and reform the clot. So you can give things high in clotting factors, such as FFP and cryoprecipitate. Also, platelets are present in them. And then deferoxamine, as promised, I gave it its own color because I don't really know what group this is. So this is a trivalent metallic ion chelating agent. Cool. So trivalent, so something 3+. So like ferric iron instead of ferrous iron, right? So it's going to be a chelating agent of your trivalent metallic ions. So it's going to chelate iron and aluminum. And when it does that, it's going to excrete the complex in the urine. So you can give this for like acute iron poisoning. It'll just like sequester the iron and then it'll excrete it. But something to pay attention about is it acts as a siderophore for rhizopus. Siderophore is just like an iron binding thing, right? So it's it basically is something that binds to iron, which is exactly what it's doing, right? It's going to chelate iron. But when it does this and if you have a concomitant infection with something called rhizopus, which is a type of fungus, you can get it can actually make rhizopus stronger. Like it's like, oh, cool, like my iron's here for me. And then it can take its iron, it can grow, and then rhizopus can cause something called mucormycosis. So you get this increased risk of this disease. You probably haven't covered it yet. You tend to do mucor and rhizopus and stuff during your diabetes. They're microbes that tend to be present in patients with diabetes. But just kind of like this weird farm micro thing that it acts as a siderophore. And then I kind of have here like many bacteria make siderophores so they can go and scavenge iron from the environment. Deferoxamine is already doing that for these bacteria, these fungi, these microbes. So it can actually like increase the risk of certain infections. But the reason I wanted to include it, so this is the real reason I wanted to include it, because none of this has anything to do with heme, is remember oh my God, I can't say this word. Dexrazoxane, okay? Dexrazoxane is the antidote for actinomycin D. So actinomycin D chemotherapy, one of the side effects of actinomycin D is cardiotoxicity. It's actually super cardiotoxic. It can cause like a dilated cardiomyopathy. And you reverse it with dexrazoxane. Dexrazoxane also is an iron chelator. Okay? Don't get confused with these two with deferoxamine. They sound almost exactly the same. And if you're doing questions and you see it, I don't want you to like pick it like just because you're like thinking. Like you want to pick dexrazoxane and then you pick deferoxamine. I had this in my heme notes, like this drug, I had it in my heme notes, and I think that's probably why, is because I was like, probably kept getting it confused with this guy. So don't get confused, don't get got. Great. And so here's where we're gonna end. Hopefully you guys got this one. This is a good one. I'll put the answer in the bottom of the notes. All right. But hopefully that was helpful. Good luck on your exam. Let me know if you guys have any questions at all. I'll be around. And yeah, good luck.